Greetings everyone to another episode. Am I sharing that? Okay. And welcome to Oral Pathology 360. I'm your host, Dr. Mandana Donahue, and today we are going to be discussing cleft lip and palate. Now, as dentists, of course, this is not a new topic to us. All of us know what it looks like and the problems that patients will be having when they have this condition, and also their families often will be facing many problems as these children grow up. Now, here we have this adorable little boy called Pablo. Michelle, his mother, says that today he is a bundle of energy. He goes to school, he enjoys maths, he enjoys physical training, he does a lot of Lego playing, he loves videos. He's essentially very like any average, normal little boy, I would say. But he is able to have that normal life because this is how he looks like today. He is over 5 years old, and he has gone, of course, through a number of treatments, surgeries, a lot of things, speech therapy, and sometimes it's getting tough for him, but he's putting it up and he's managing and he's fighting it, and his family and friends are supporting him, and he's having a normal life. But that is because he was treated on time and his condition was diagnosed on time. For that wonderful outcome, to be the regular, to be the norm for every child born with this condition, it is us, healthcare workers, dentists, anybody working with children, who need to be able to identify and appropriately direct these patients, rather their families, to the right people at the right time. Even if we are not treating them, we need to know what needs to be done just to be able to guide them. And to be able to do that, today we have with us Dr. Somia Tripati. I have known her and she's been on the channel before. Last year for Women's Day, we had a Women of Dentistry episode. And the first thing, I've of course known her from before that. She was a student where I was teaching. She was doing her master's there. But we really connected last year. And the first thing I remember is when I asked her, "So, what are you doing nowadays?" And she said, "I'm working with Cleft, work with on the spine train." So, this is obviously something she's passionate about. And this is what she's continuing. She's currently attached to the Meenakshi Hospital, Tanjavur. She's a project director for Smile Train. She's also a fellow of the AOCMF at Charité University Berlin. Then she is also accompanied today by one more person who is equally dedicated to this and who is taking care of another aspect, and that is the speech problems these little kids have, these little bundles of joy. But well, so she has done her PhD in speech language pathology, and she's a consultant speech in the same topic, and she's a PhD on the same. She is currently attached to the Bhagwan Mahavir Jain Hospital, Bangalore. I have to say thank you to both of you for being with us today. It is so nice that you could join us, and I hope we will have a great presentation on this topic and a lot of discussion at the end. So, with that, I am going to stop this share so that, yes, welcome to you both. I'm going to let
Thank you.
Dr. Soumya start. Soumya, are you ready? Right.
So I just
Good
need to
morning,
confirm
like
if my
everyone. Yes.
is it in
Well,
presenter
it
mode?
no, not yet. It is
Okay,
in the
I don't know.
multiple slide view mode.
Okay, I'm really sorry, but I think I should then start. Anyways, good morning, everybody. It is my great privilege and opportunity. It's honor to be called by ma'am and to speak on cleft deformity on such a platform, which gives me uh, like a wide audiences to spread the awareness about the cleft treatment. And like ma'am said, from the beginning, I got associated with the cleft surgeries, and I'm enjoying it. So will quickly tell how I'll be covering the topic, a brief introduction, a brief overview on epidemiology, etiology, genetics, and embryology of uh, cleft deformity. And then we would see who all are needed in a cleft team and the sequence of interdisciplinary management to deliver a comprehensive cleft care, and then, of course, the summary. So, until I joined my residency, I had never seen a cleft baby. And when I came to know, we all read every one child born in 700 live birth is a cleft child. That amounts to around 35,000 cleft babies getting born only in India. And one of the statistics from United States of America, a research statistic says that every 2 minutes a cleft child is born in America. Imagine how many of them are getting born in India. But yet we don't come across these cleft babies so often unless you are working in one of those dedicated cleft institutes. So coming to the incidence in individual type, like cleft lip, uh, the most common is cleft lip associated with cleft palate, followed by cleft palate alone, and then other syndromic forms of cleft lip and palate. Coming to the epidemiology, so like I said, we were on etiology. So there are two factors, broadly: genetic component and the environmental factors. A lot of studies being done on genetic component, a lot of molecular studies are being done to diagnose or to find out exactly what is the reason, how does the genetic modifications cause cleft palate. But it is still in infancy, and we do not have any conclusive data on genetic study as such. Few known environmental factors are drugs and chemicals. Drugs, mainly the anti-seizure medications, retinoids, and chemicals like exposure to alcohol or cigarette smoking, etc., during pregnancy, or like even at the time of conception, rather. Then maternal metabolic imbalances like obesity, gestational diabetes, and maternal infections like varicella and rubella infections during pregnancy are known to cause birth deformities like clefts. Coming to embryology, we know that phase develops around 5 to 6 weeks of intrauterine life, and we all are familiar with these embryological pictures where the bilateral maxillary processes, they fuse with the medial nasal process and forms the uh, upper lip, alveolus, and the primary palate. The lateral nasal process, of course, forms the ala of the nose. Both the side of the mandibular processes fuse to form the lower lip and the lower jaw. Whereas the develop, so any deranged derangement in the fusion or the development of these processes, especially the fusion, will lead to different degree or of severity of cleft lip alveolus deformity. And for cleft palate deformity, it has, we know that cleft palate development takes place around 8th week of intrauterine life, wherein especially the secondary palate, wherein the horizontal shelves, which are initially vertically oriented, they move horizontally and they move towards each other, making a space above the tongue, and then these two palatal shelves move together to fuse. And any derangement in the fusion, or even if the tongue space is not created, the space which has to be created by movement of the tongue downward, there will be a lack of fusion, or sometimes even the fused palate can go for breakdown of the sutures, rather the fusion lines, and it will cause a cleft in the secondary part of the palate. So this was brief on the embryology. Coming on to the topic per se, which we will be dealing today, is to understand what all is needed for a comprehensive cleft care. The most integral part to deliver a comprehensive cleft care is to have a complete cleft care team, which constitutes of the cleft reconstructive surgeon, which we see can be a maxillofacial surgeon, plastic surgeon, in some centers even a pediatric surgeon, whoever is trained to do a cleft reconstructive surgery. Then we need a pediatrician and or a neonatologist. Pediatric nurse is very, very important because a lot of nursing care is needed. Dietitian and nutritionist who understands the caloric requirements per kg body weight and the age of the baby. Speech language pathologist, definitely needed because speech is affected in a cleft palate child, and we'll go into details of this with Dr. Aparna. An orthodontist or pedodontist, sometimes pedodontists are well trained to carry out the orthodontic requirements of a cleft baby in the early childhood and adolescence. ENT surgeon, because cleft palate children most of the times will have eustachial tube dysfunction, recurrent otitis media because of recurrent upper respiratory infections. So ENT and some even hearing disorders. So early intervention for screening, ENT surgeon is needed, and sometimes also for some therapeutic intervention as well. Psychotherapist and psychologist, like ma'am mentioned in the beginning, with all these procedures, with the deformity on face, it does take a heavy toll on the psyche of the baby and also the family. So, a parallel care by a psychologist or psychotherapist cannot be undermined. A counselor, of course, and social workers, they play a very important role at the grassroots level to bring these babies to us. A networking with many other NGOs, the ones which are dedicated for cleft care surgeries. At the same time, we need many other NGOs, people who are well connected with the patients, and sometimes in our country we see even door to door screening is needed to find out if a cleft baby. So they are well informed and they help us a lot to be able to deliver whatever expertise we have. So, with this cleft care team, we see how this interdisciplinary management, in what sequence they have their roles, and how crucial it is to deliver the comprehensive care. So, I have tried to divide it into 6 stages. And first is prenatal period, then 0 to 6 months, 6 months to 2 years, a preschool age of around 3 to 5 years, childhood, that is 6 to 12 years, adolescence, and young adulthood. So, this is a rough division. Sometimes it is like, especially for the surgical intervention, it can go depending, because we do not follow a very strict chronological age, as in calendar age, but it is more of a customized treatment for the baby depending on their growth and development and how fit they are for procedure. So it is a rough division which will give us an idea. Coming to the prenatal, the first sequence is prenatal. So the treatment or the management of cleft deformity starts from the moment a couple or expecting parents come to know that they have a cleft deformity baby in the prenatal scan, which is done at around 16-20 weeks of gestation. That is when it is detected. And nowadays we even have 3D ultrasonography scans. The one you are seeing on the screen, it shows very, anybody can pick it up clearly. But then there are factors. Not every time we come to know, we ask the patients, they tell we had several scans and nobody told that we had a cleft deformity baby, otherwise we would have not considered giving birth things. So doing a scan is like a both advantages and disadvantages, because sometimes it's really heartbreaking for the parent, but at the same time, if they are counseled well, they are well prepared to receive a baby with a deformity. But there are factors which affect the accuracy of the scan. First is how sophisticated the equipment is. Like I said, this picture shows a 3D ultrasonography, and it is very easy to pick, but not every center will have such technology. So it depends on equipment, obviously the skill of the sonographer, how many weeks into pregnancy. Later on, as the face well becomes more well formed, it is easier to pick. So in the 16 to 20 weeks of scan, but later on it is picked and they are informed. Position of the baby while the scan is being taken, especially the isolated cleft palates. Sometimes it is missed, and when the baby opens the mouth during the scan or something like that, then it is picked in subsequent scan. Also depends on the amount of amniotic fluid and the severity of cleft. So if it is a very protruding premaxilla in a bilateral case, it is difficult to miss. It is easily picked. So like I said, it's a simple soft palate cleft, not very easy to pick. And there are transvaginal scans also, which can detect the deformity even at around 10 weeks of gestation, but those are not routinely practiced for screening. Coming to the second stage, that is around 0 to 6 months. So 0 to 6 months, we have to be careful. Like that includes the neonatal age, that is less than 1 month, and then the infancy, first 6 months. So first thing is airway. So if you see a baby which is born with cleft lip or palate deformity, the first thing we should be careful of whether the baby is able to breathe well. Is there any increased effort of breathing? If you have to check for the one has to check for what is the position of the tongue, because in a baby like this, if you see, it is a condition, everybody, we all have read about Pierre Robin sequence, but it is sometimes it can be a very challenging situation to manage, just because of micrognathia. The mandible is so small that there is hardly any space for the tongue, and the tongue falls back. That is called as glossoptosis, and it almost occludes the upper airway, and therefore there is increased effort in breathing. And you can very clearly see the accessory muscles of respiration. There will being very active. There will be clear pre-sternal and pre-sternal indrawing, pretracheal indrawing, which shows clearly that baby is putting in a lot of effort for breathing. So if and now everybody can check like oxygen saturation. So if a baby is found to be breathing with effort, and you can see clear stridor, like gurgling, snoring sounds, and if you see that it's not maintaining good oxygen saturation, then an emergency intervention is required. Baby should immediately be sent to the nearest neonatologist and pediatrician. So I have encountered babies, they have come across where they were not even such difficult breathing situations were not addressed even for a month or 45 days, and eventually there is failure to thrive. They do not gain weight, and they are losing, there is wasting, and they do not grow well. So this is a very important thing first to check is the airway. Next is feeding and nutrition. Of course, after airway, next comes for a newborn is feeding and nutrition. Because of a deformity or lack of lip seal, there is, I'm talking about the cleft lip first. Of course, there is no latching. They cannot lock with the mother's breast and nipple. So it is very difficult for them to suck. Basically, there is no problem with the swallowing, but that rhythm to form with holding the mother's breast and able to suck and then swallow, it takes some time. They learn. But if there is a cleft palate, definitely there is no uh, negative, they cannot create that negative pressure to suck, and there is no seal, so they struggle. And whatever little milk goes, the calorie requirements are so high, all the energy is gone in just trying to suck the milk. So this is one of the faulty feeding habits, and this immediate intervention is required, and feeding and nutritional counseling is done. And there are various methods, there are various types of cleft feeding bottles, and every local area will have their own technique, spoons and other things, and any expert cleft pediatric nurse will know how to teach them about feeding once. And babies learn very fast, infants also learn very fast. Like once they know, they will develop their own mechanism to seal the airway with the position, by positioning their tongue. And but that coordination has to be taught in the beginning. Next comes hearing and speech evaluation. Hearing in nowadays in all the good centers, neonates, they are doing better hearing tests to make sure that there are no hearing problems, and definitely speech evaluation comes much later. But if there are hearing is- issues in the beginning, definitely it is going to have speech problems later on. So next, coming to pre-surgical, so I would like to show you this baby, which was like almost cachexic, lower than the birth weight after even 1 month of uh, age, and after simple feeding, just telling them the time and the quantity, and they are basically scared. The parents are very afraid. They do not know how to feed, and they think that if they put a bottle or a spoon in the mouth, it might be painful for the baby. So just simple counseling helped, and we got good weight. And this child, next post-op photo is when he is around 2 years of age. Next, coming to pre-surgical orthopedics. So this is a case of bilateral complete cleft lip. You can see how uh, projected and protruded the premaxilla is, because the vomer and the premaxilla is growing unhindered, like uninterrupted, and it becomes very, very difficult procedure, surgical procedure, when we have to operate. So to make sure that we do not end up in a situation like this, we have something called pre-surgical orthopedics. What you are seeing on the screen is an appliance, which is also called, with the technique is called nasoalveolar molding. And so it has three parts. The one part, which is a plate, which goes and sits into the palate, and which also assists with the feeding. So there is no regurgitation into the nose, whatever milk is given. And the tent like the wire and a small bilobed kidney shaped structure, it goes and sits into the nose. And then there is a taping which helps the to mold the shape of the nose, and also doesn't allow the central maxillary element to grow uninhibited. So it makes the situation very, very conducive for a good surgical outcome. There are other simpler methods. If this it looks very, it is definitely technically very sensitive, and only an orthodontist who is trained in pre-surgical orthopedics can deliver such an appliance. But if such facilities are not available, a simple taping also helps to bring the cleft segments together, and makes the surgical outcome better. Then, coming to the surgical part, within 6 months of age, the primary lip repair is done. As you can see in the picture, how the orbicularis oris, the circumferential band, is oriented or disoriented and gone and getting inserted into almost into the floor of the nose and anterior wall of the maxilla. So when we say surgical repair, it is not only just the closure of the two skin segments. It is more than that. We is in the surgical procedure, we need to detach the faulty or defective insertions of the muscles, orient them in the right anatomical plane, and then close in different layer, mucosa, muscle, and skin. For a patient to be fit, we have been reading like since ages the rule of 10, that is 10 pounds of weight, 10 grams of hemoglobin, and 10 weeks of age. So that is a minimum criteria. It is not needed that the minute these three parameters are met, we have to operate. I personally keep my parameters on a higher side, so it gives me an advantage, because anyways, after immediate post-op period for 1 week, 10 days, babies are going to lose weight. So it is always better to be on a higher side. But of course, within 6 months, we do lip and simultaneously nose correction in a unilateral. This is one of the cases of complete unilateral cleft lip and palate, and this is around 1 or 2 months after surgery. And you can see even the nose. Now with lip repair, in the primary lip repair, we address the nose and do the rhinoplasty as well. Some other cases, and these cases the pre-surgical orthopedics were not done. Otherwise, the nose results are better. These are some few more cases of unilateral complete cleft lip. And this is a very wide defect. And sometimes still we get patients, she is a 36-year-old lady who were brought to us by her husband after marriage, and she got operated and she was very happy. Coming on to the bilaterals, so you can see how the muscles insertion, and in bilateral it is the same thing on both the sides, and in the central segment, like I was telling, the that is called the premaxilla, and the skin, the prolabium, that becomes a challenge if it is not addressed in the. I must mention that for pre-surgical orthopedics, and which includes also the molding of the nasal cartilage, we have to start it within 2 weeks of age, because it is said that we take it gives us an advantage of maternal estrogen which is present, and it helps us mold the cartilages and contour them in a more favorable position for a better surgical outcome. So this is one of the bilateral cases, though it is not very severely protruded, but it is width is more, so it becomes difficult to get a good closure. So it is a simple one. So here you can see only the soft tissue segment. It was only an incomplete cleft lip where the nasal floors are intact. So it is not so difficult as compared to the previous one. Again, at this stage, he was still not operated, and he was around 19 years, and he was living almost like a recluse, and he wouldn't meet anybody, no friends, and you see, he looks almost normal. Then there are some other clefts other than typical cleft lip and palate, called comes into category of facial cleft. So this is just an example. It has a very elaborate classification given by Tessier, and it is these clefts are formed due to lack of fusion of like embryonic fusion lines, and they can range from the entire face, involving the forehead and medial canthus of the eye, and lateral canthus involving the nose. And this is one of the Tessier's 7 examples. Here you can see on the lateral side, the oral commissure is little more extending more towards the ear, and this is after repair. Coming to the second stage, that is between 6 months to 2 years. So 6 months to 2 years is the time for cleft palate repair, preferably after palate repair, preferably after 7 to 9 months, greater than 9 months of age. But there are different protocols in some centers, especially European countries. Some places they do operate soft palate first, and later on come to do hard palate. But mostly in most of the Indian centers, we do it after 9 months of age, and once the baby is otherwise fit for surgery. Then there is one more procedure called insertion of tympanostomy ear tubes, or grommets. So these are like ear tubes which are inserted during the palate surgery for the babies who have recurrent otitis media, and that happens due to the lax eustachian tube, and they are not able to clear the secretions. Therefore, these grommets are inserted, and these are done by an ENT. So that is why I said ENT surgeon's role is also very important, especially in babies who have eustachian tube dysfunction problems, and that has to be screened in the early stages. So, coming on to the cleft palate repair, briefly on the anatomy, if we all remember how the velum, the soft palate muscles, and there is a sling movement uh, of the muscles which help the soft palate move, And Dr. Aparna will be talking in detail about the velopharyngeal seal and how it affects in speech. So you can see how in a cleft palate the entire muscle orientation is changed. Instead of forming a sling, it is antero-posterior oriented. So what we do in surgery is again release these muscles and bring them to the right orientation and try to close it. And mostly it is there are different techniques. I'll not go into details of surgical techniques, but few examples. So I like a cleft palate. These are the examples of cleft palate. It can be a bilateral complete cleft palate extending right from the floor of the nose, primary palate, to the soft palate. Then the picture on the left lower, it shows an incomplete cleft palate. Just the secondary palate is cleft, and then there can be a unilateral complete cleft palate. In whatever be the severity of a cleft palate deformity, speech is going to be affected. And if it is also affecting the hard tissue, depending on the severity, width of the cleft palate, the growth of the maxilla is also affected. One example of cleft palate repair, this is immediate post-op and late post-op. As you can see, it is again an adult patient with all full complement of teeth. So we still get we still keep getting adult patient unoperated cases, though like our seniors tell, when they started 15-20 years back, they used to get lot of adult patient, but we do not get that many these days, thanks to organizations like Smile Train and many other NGOs who have intervened, and they have improved um, the condition, and they has helped us operate babies at the right age, uh, and following the protocol we do get optimal results functionally and both cosmetically. Coming on to the preschool age, that is between 3 to 5 years. So if there is if around 4 years, when they go to school, and sometimes small children can be nasty and they tease and they become very conscious of their looks and they hesitate to make friends, then it is the time to intervene and do something called preschool rhinoplasty or a lip revision. I wouldn't do it for all the babies, but when there is real, when you identify that it is really impacting their psychological growth, social growth, then we have to do sometimes. And it also depends on the parents. Sometimes not the baby, but the parents are more worried. So very rarely I do go for lip and nose revision at this stage. Then speech assessment and correction of VPI. This Dr. Aparna, our expert, she will be telling us about speech and VPI. Then sometimes if there is the healing of cleft palate has not been good and there is a oronasal fistula, we need to close it, because that is also going to affect the speech, and it is going to affect the oral hygiene. Parents will complain of nasal regurgitation of food. So this is the time we can close it. And then, of course, it is the time also to address, to look for the primary dentition, to evaluate the primary dentition. So this is one case of primary rhinoplasty, preschool rhinoplasty and lip revision. This is how it's an operated cleft palate, but there is a residual fistula. So it is after the closure of the cleft palate fistula. Coming to childhood, that is between 6 to 12 years of age. In this stage, we need to go for phase 1 orthodontic treatment, then assessment of facial growth and alveolar cleft repair. Phase 1 orthodontic treatment basically is where you see that the mixed dentition stage, and it doesn't, like I said, it doesn't depend strictly onto the chronological age, but it depends on dental and skeletal age rather. And it is when the permanent dentition starts erupting, and you see that there is a significant collapse of the arches, or the arches are not aligned. So this is the stage when an orthodontic intervention is first started, and it essentially involves expansion of the arches. and that is for any kind of orthodontic intervention. We definitely need at least first molars to be erupted, because if they want to put the bands, first molars, then we need the first molar, permanent first molar there. And we also see if we do an OPG and other imaging to find out if there are any permanent teeth which are congenitally missing, which is a common finding, or sometimes they are also damaged during the primary cleft palate procedures. So in that case, or they may be malaligned or not erupting because of alveolar cleft. So all that planning and evaluation is done at this stage, and depending on the formation of the root, we plan the orthodontic treatment, and depending on the how severely collapsed the arches is, we go for the orthodontist plans the treatment for the baby. Assessment of facial growth, of course, we all know that because of surgery and also because of the inherent growth restrictions of the maxilla in a cleft patient, we are always worried about the facial growth. So mid face is deficient, mid face growth is deficient, and sometimes orthopedic appliances like face masks, etc., are used. So that is why we need to have a very regular evaluation or assessment of the facial growth, and early interventions are done if there are indications of severe maxillary retrusion. Coming on to alveolar cleft repair. So whenever there is a complete cleft lip palate, the alveolus is also, there is a gap in alveolus that is filled with bone grafting. So this is, like I said, in part one orthodontic, this you can see how the arches have been expanded by different orthodontic appliances. The collapse arches, that is when we get a space for the cleft alveolus to be filled by graft. So this is one example. You can see the wide cleft alveolar gap, cleft alveolus, and this is the bone, which is most majority of the time bone is harvested from anterior iliac crest, co- cancellous bone and marrow, and there can be other donor sites, but iliac crest is the gold standard from where we harvest, and this is after grafting into alveolar cleft. Coming on to the adolescence and young adulthood, which involves phase two orthodontic treatment, which is again around 13 to 19 years of age. And this phase two of orthodontic treatment mainly deals with maintaining the arch width and uh, what we have achieved. So after bone grafting, we do not want the arches to collapse again, so there are retainers to maintain the arch widths which we have achieved by after expansion and grafting, and then aligning the permanent teeth, basically getting the patient ready for future orthognathic surgery if indicated, or if not, then the leveling and alignments. Then it also in this phase, if the patient has severe maxillary hypoplasia, will go for maxillary orthognathic surgery. Orthognathic surgery can be a conventional orthognathic surgery, LEFO advancement, or it can be anterior maxillary distraction or full maxillary distraction, depending on this. So, like I said, it is case based plan, and accordingly the surgical procedure is decided. Once the orthognathic surgery is done, next we see if there are any residual lip deformities, any asymmetries or nasal deformities. They are addressed only after the skeletal correction is done. And then if there are any replacements needed in the cleft deformity line, then prosthetic replacement of the dentition is done. Also, there are adjuvant procedures which can be done to make they may not be uh, like sometimes we get better results by minimal interventions, like for a not very symmetric lip, you can do fat grafting, or for male men, we do hair transplant in the mustache, which they are very conscious of. So these are other adjuvant procedures that can be done during the young adulthood. So this is one case you can see of mid-face distraction for a severe maxillary hypoplasia. This is a secondary correction of lip and nasal deformity, that is definitive rhinoplasty. So there is the nasal deformity is very typical. The lower lateral cartilages you can see is slumped, and the alar base width is more on the cleft side, and the nasal tip is also deviated, and the nasal, the columella, the septum is deviated, and the tip is not well defined. So these deformities are addressed and after the orthognathic surgery. This, like I said, uh, for men, if there is a scar in the wide scar, sometimes it can, especially in bilateral, the hair doesn't grow, and it's not very. They are not confident, and we can go for hair transplant in the lip scar for post lip. Just to summarize, so like we saw, first we need to go, the first stage is prenatal counseling. The moment parents uh, identify that there is a cleft deformity baby, they immediately need counseling. And I must emphasize here that unless it has been found out that it is a syndromic cleft fetus, it doesn't need to be aborted. And this awareness at this platform, I would want to spread that it is a treatable deformities, and parents should be counseled in such a way that they must continue the pregnancy and should not consider abortion, because it is a treatable deformity, treatable disease, and it gives good result if done in the standard, in a standard following a standard protocol, and done at a good center. Next comes neonatal stage. So like I said, airway feeding has to be taken care of. And in general assessment, I must mention that there are other associated anomalies sometimes found, like cardiac anomalies and sometimes renal anomalies. So routinely we do at this stage in the neonatal period, we do, if clinically any murmurs, or if there are other clinical indicators, we go for 2D echoes, echocardiogram and ultrasound abdomen, and good clinical examination by a pediatrician to rule out if there are any other associated anomalies. Sometimes we find the deformities in digits and clubbed, the syndactyly, polydactyly, etc., other than the cardiac and renal anomalies. Like I said, kiloplasty, it can be done after 3 months of age, but that is not a permission that once the baby is 3 months, you can operate. There are other factors. Basically, the airway has to be mature enough, it has to be developed enough to sustain the post-operative, post-general anesthesia stress. So we rather go for general growth and development, instead of following the strict age criteria. So hemoglobin should be good, and if the babies are like, even if the weight is good, hemoglobin is good, age is correct, but if the baby is syndromic, we still need to, if there is global developmental delay, we still need to postpone, and we are not going to gain anything by operating a lip and risking the life of the baby. Palate can be operated anytime after 9 months of age, but preferably less than 1.5 years of age, uh, because it will start affecting the speech, because around 9 months to 10 months they start babbling, and before that it is good to have the correct anatomy in place. Coming to speech therapy, can be started again depending on the age of the cognitive growth of the child, if he can accept after 18 months of age. Coming to alveolar bone grafting, that purely depends on the dental and skeletal age of the patient. Then secondary correction appropriate to age, like rhinoplasty, speech correction surgeries, orthodontic treatment and other dental treatment, orthodontic surgery, and adjuvant procedures, like I mentioned. Thank you so much. Um, I would want to tell that WHO has, at this stage, I would want to tell WHO has included cleft deformity into the global burden of diseases list, and this was done more than 1.5 decade back, and this shows that definitely it is a deformity, it is a disease which needs the awareness needs to be spread. And despite it being included, and despite uh, uh, research work and awareness campaigns being a lot of work being done by so many NGOs and research institutions, still there are patients who are not getting operated at right age. And it is not the patients, I have felt, even the general practitioners whom the patients they see for the first, they are not aware of the right protocol, the right timeline, and the treatment sequence. And please, with us and Smile Train, those who are active with social media, spread this awareness and make this noise and let people know, and join this awareness campaign that Zor se bolo cleft is treatable. Thank you so much.
Thank you, Soumya. That was a very nice and very detailed and really, actually, to the point. I would say not unnecessary. It was just
Did I
right.
keep my time?
Yes, you kept your time in spite of everything, which is cool. Yes, that is cool. Yes, it was good. Thank you so much. So now I'm going to ask our audience if they want to
So
make
I
any
have
comments or
Dr.
yeah, 1 second.
Aparna
Let
with
let them
me.
type any comments and questions that they have because there will be a little time lag. Right now, I will ask in the meanwhile for Dr. Aparna wanted to share something, so I think I will let
Yeah,
her do
I
that. Yeah.
Thank you, Dr. Mandana and Dr. Soumya, for having me here. Uh, so I just wanted to add on to what Soumya had said and just throw some light into a allied field of speech therapy, which probably the audience may not be aware of. And I wanted to emphasize on why speech disorders happen in CLP and why is it important to treat it early and the timeline of treatment. So that is a little ongoing treatment which probably the people who are going to refer patients to a cleft center should know about. So speech disorders in CLP happens because all our speech sounds are very intricate productions where the air coming from the lungs is modified inside your mouth in various ways, and the air pressure needed for producing each sound, say per or bh or t, everything is different, and we need to have a proper airflow being blocked inside the mouth by various articulators, which is our active and passive articulators. And any difference in that would definitely cause an interference, and it would make the sounds entirely different and make it sound as its own language. If all of us had cleft, probably we all spoke the same language. uh, so there are high pressure, low pressure sounds, and even after Soumya said that when a child starts speaking, if the cleft is not repaired, definitely the child will learn that as a sound, which is produced from the nose or produced from the throat, which is different from our language. And even after this cleft is corrected, say 10, 9, 10 months, still there is chances that the babies start cooing and babbling by 3, 4 months of age. Still, they would have learned some errors. Clever kids replace that when adults give right feedback, but all of them may not need it, do it. So definitely, an early intervention or early look into all these details are very necessary. So usually in a cleft unit, we start seeing babies as early as 1 year of age, even if the cleft is not repaired, especially to look in for this associated conditions like hearing loss or syndromic cleft, which would still cause a language deficit. The child may not, it's not about the cleft affecting the child, it can be the other associated conditions also affect this child's language development. So language need to be focused on. Once the language develops, then the further thing is how the speech sounds. So cleft has typical speech errors which is not present otherwise in a normally developing kid. So we might still hear children with normal typical typically developing kids substituting one sound for the other sound in their developmental period. But in children with cleft, they do it differently, and we need to assess that early itself to identify and make the parents also aware of that the child's production, and so that they can train them at home early itself. Once the speech sounds in terms of the errors are established, we need to look into why this is happening. It can be because of the deformed teeth. It can be due to velopharyngeal dysfunction where the velum is not sufficiently closing against the posterior pharyngeal wall. It can be due to a persisting fistula, or it can be anything learned by a child. So there are these the what I listed down in the screen as a typical disorders. We are not going into any details of it. So my next slide, please. So, in correspondence with the timeline, what Somia had mentioned in her presentation, I would like to emphasize that the referral to a speech therapist still continues in an older age too. So, it can start anytime in the early age where when the cleft is not repaired, or even after the cleft is repaired. So, we need to keep them on review till say 6, 7, 8 years to know if the child has learned all the sounds correctly and is going to speak like normally like us. Um, if it is not happening, the assessment in terms of any velopharyngeal dysfunction for the surgical correction need to be planned with the surgeon after doing an instrumental assessment, which is usually available in specialized cleft centers. And even at the later stage, after 16 years, the client is undergoing an orthognathic correction, we need to still check on if the speech gets affected pre-operatively to decide on the surgical protocol itself. So everything happens in the team and close ally with the surgeon and the orthodontist. Next slide. So after all these the next thing we look for is, yeah, so these are the instrumental assessments which is commonly available. And the speech intervention would focus on correcting the speech errors as well as improve the quality of the speech. So you could still understand if I speak from my nose, but it doesn't look good because you want me to speak normally, which is acceptable for your regional language. So I need to make sure that the child's speech is also acceptable and nobody is bullying them, taunting them on a later stage. Last slide. Please not skip this slide. So the desired outcome of successful uh, cleft palate surgery is to have an intelligible and acceptable speech skills. Team approach is important for appropriate treatment planning and early identification of the structural deficit and initiation of speech therapies for the best outcome. Yes. Thank you so much.
Thank you, Dr. Aparna. That was also very, very useful. So let's see what we have here in the meanwhile. First, we have Dr. Nasser from the US who says, great presentation, fantastic results. Yeah, those were actually. And then we have Dr. Ratua. That's, I guess, for you, Dr. Aparna. Is stuttering a speech disorder?
Yes, it is a speech disorder. It's called fluency disorder. So where the it's mainly related to a behavior which is learned due to a dysfunction between a coordination between your speech subsystems and your brain and what you intend to speak, and then it connects to emotion, anxiety, all those together. Yes, it's a fluency disorder which need to be treated, can be treated.
Okay. So, anyone has any other questions? I don't really see any other questions. So, tell me how much of this treatment, whether the part which is surgical, so I will ask you for that for you, and whether the part that's speech, how much of it requires any form of a physical therapy, maybe exercises by the child or anything that the child has to do on a regular basis?
Okay, I think I
Yeah.
will. Yeah.
Yeah.
So
Yeah.
yes. So it's basically speech can be learned only by practicing speech. Okay. So we see general practice is that no, most of the time I get patients where the surgery is done and the surgeon would have told them, or anybody would have told them to practice blowing a balloon, okay, or practice blowing candles to improve on the velar movement. But actually, it doesn't work because the neurological mechanism for the speech itself is different from other non-pneumatic or pneumatic functions. So you have to practice speech, and physical speech therapy will be required, and it can be as long as 2 years or 3 years sometimes, because it all depends on the learning capability of the child. Because you already internalized all these errors, you have to unlearn all these errors, and you need to relearn all these correct predictions.
That's true. I think unlearning anything is always the most difficult.
Yes.
Yes. What about the surgical part? What about the physical structures? Does any form of therapy help there, Dr. Somia?
Not really. But yes, I do not have. I mean, it is all anecdotal. But physical therapy, not anything done by the patient per se, but sometimes after lip surgery, the scar and all, we do tell them to do massages, and if you can consider is any form of physical therapy in the sense you are thinking the role of muscles,
Yes.
musculoskeletal. So we tell them, then I'm really not sure how much it helps, but nothing can replace a good surgical, procedure done. So everything else, honestly, it is like when
No,
surgically
no,
you have
I'm
not
sorry, let
achieved
me
the
interrupt you.
optimum.
Sorry, let me interrupt you. That was not at all the intention. I think the treatment is essential and is first. What I meant was as an adjunct to, so you have done the treatment and then,
No, I
let's say, like the way, orthopedicians would tell a patient, okay, now I've finished your treatment, but now you need to walk, that sort
not
of a
for
thing.
cleft surgery.
So,
I cannot think
okay,
of
nothing
in
like
any
that.
way. Yeah.
Yes. In any way that, any form of muscle movement would help. Okay, for
No,
that
no.
to get accommodated, right? But this, of course, speech, any which ways, I think essentially speech, even as in general, there are people who actually, help you to speak better, sound better, enunciate better. So I think that is fairly normal, and all of it requires practice. So that
Yes.
would require some practice under guidance. Yes, true. So there doesn't seem to be any questions. I think the presentation was fairly thorough. So yes, there's nothing left to ask. And what else would you like to say to everyone out of the, let me ask Soumya first, out of the how to manage, which you covered? You were mentioning something about putting the message out in social media. So,
Yeah.
what is the message you want out on social media, and what do you see coming out of that?
So one thing is, people must know both medical and non-medical, because it's a very there are very few specialized surgeons, or like Dr. Aparna's, very few among all the speech language pathologists. Not all are interacting with cleft or dealing with cleft patients regularly. Similarly, not all the orthodontists are doing cleft orthodontic. Not all the surgeons are. So same way, uh, even there are surgeons, even there are pediatrician, even there are uh, speech therapists who do not know, who are not well informed with the, not well updated with the recent protocols. Forget about people who are not, are of different specialty or non-medicals. So the social media message which I want to spread is like, please understand, please spread this message that it is a treatable disease. There are dedicated centers which are doing it, purely cleft surgery, which are doing only cleft surgeries. There are trained people, and it is free. If it is being funded by an NGO, it is free. Free means zero bill. So take good patients should be referred in right time to the right place, and they should be encouraged that treatment should be given, and children do become, I cannot say they become absolutely like every non-cleft, but they get optimal functional and aesthetic results, and rarely they look almost normal. few, if everything was done in right time, and they were lucky enough to get into right hands. So yeah, so this is the message that it is a treatable disease. I know people who, though it is not legally allowed, they abort babies. Even OGCians are not aware that it is a treatable disease, and you don't need to abort a baby. He or she can be operated and can become normal. They abandon children after they are born. So if we spread this message and people know that it is treatable, they don't need to do all those things. There are so many diseases, you know for
Much
which,
worse.
yeah, so a lot
Yes,
of
there are
work
many
is
diseases
happening.
which are much worse. Yes.
Yeah,
I also think, normal is a very relative term. And I think also it is
but at
something
least, yeah,
where it all depends on one's attitude. If that child grows up to be, confident and comfortable enough,
yeah.
who's to say that they are not, that they look anything but that? That's just the way they look. It's a very relative term. But the main thing is, I think, the psychological effect, and that we can help that with all the care that is possible. Yes. And
Yes.
definitely no
And
child should
when
be
these
aborted
children
today
come and
because
get
of this.
treated to, sorry.
No, no,
So
go
when
ahead.
these parents and children, they come to dedicated centers and they see other, they are not the only one. They get encouraged. They get confident and they understand. Okay, and when they see a good result, a patient who is almost getting their treatment done on the, all these things work. That is why they must be sent to the dedicated centers where we can actually give comprehensive cleft care. It is not about isolated one lip surgery, which anybody can do, or just any speech therapist, some sessions of speech therapy. It doesn't work like that. So that is why we have dedicated centers. So one must refer them to their nearest Smile Train or any other NGO. Yeah,
That is true. Yes. So in India, the treatment is free as far as it is with any of
yeah,
these
if it is being
organizations
funded.
like
Yeah.
Smile Train.
Yeah. Yeah.
Yes.
Okay.
This is
I do
including
wonder
speech
the rest of it.
orthodontics. No,
Yeah.
this
Okay.
free
Whole
services
treatment.
including speech, whole
Okay.
treatment, including
Entire. In
psychological,
fact,
nutrition, yeah, everything.
nutrition, we take care of, give
Yes.
them if they need, they are being given nutritional supplements, milk, whatever they need, travel allowance.
Yeah.
That is cool. I don't know how it is in the other countries. We have Dr. Nasser here from the US, Dr. Hiller from South Africa. Yes, the Dr. Nasser is saying this.
Yeah, he's telling.
Yeah, there are many missions that travel worldwide
Yes,
to operate, so help is
yes.
available. That is true, yes. And so I don't know, but there are also, besides who's right now attending, thank you, Dr. Nasser, yes. But I think besides everyone who's attending today, all those, if you are watching this later, or if you're watching it today, from whatever country, because we have people watching the videos from 32 countries in the world. So do leave your comment. You are on the dental and the medical side. Leave your comment as to what is the situation in your own country and how people can find help, and whether that help is free or partly funded by the government. The right people will always find an answer somewhere. So put it down. It will help somebody somewhere along the way to know that a responsible person from within the dental or medical world has left an answer. That makes a difference. Yes, and I think this has been great, and this is something that we hope will reach much further. And just for your interest, Soumya, you shared that question with me, and I put it up everywhere. The question was, what could be the cause uh, of a palate of a cleft palate baby being underweight or not gaining weight? And we had some options. So the options were, first was the faulty feeding practices. The what was the other one? I forgot the first one. The faulty feeding practices, I remember, but and
Existing cardiac anomaly,
yeah, the existing cardiac anomaly, and there was one more which I have forgotten, the first one.
failure
So
to thrive, or some airway
airway, yes,
obstruction.
airway obstruction. So very few of us, and I have to accept, even I did not know the right answer, but until you told me. But very few of those who actually answered it around on It was on Facebook, it was on Instagram, it was on Twitter, and it was on LinkedIn. So everywhere, very few actually got the answer right, which was all of those things together, all the
Okay.
options together. So, and anyone who was interested, well, that was the answer. The answer was all those possibilities can cause. And clearly, much as we learn this when we are all doing our dentistry and as we are getting trained, we learn this, but everything keeps moving. And when we move on with our practices and with our specialities, we don't necessarily get updated on everything. We get updated on what we do, but this is something that, very frankly, I think every one of us need to be updated, because when we see a patient like that, we can guide the parents. We can tell them there is hope. We can tell them who to go to, what specialty to go to. And that's something we all need to know, irrespective of what we do otherwise within dentistry or medicine or nursing or wherever we do what we do. So, with that, I think I shall just share your, yes, certificates and with our thanks. Thank you so much. Somia, I hope you will be back with us again soon.
Yes,
Is
ma'am.
this shared?
Anytime. My
Yes,
pleasure.
yes. Welcome. It was really nice having you here. And yes, Dr. Aparna, thank you so much. I know you were traveling right till yesterday, so this was a little difficult for you. Thank you anyway. It was really
Thank
useful.
you. Thank you. Thank
Thank
you
you.
so much.
Thank you. So, also, this is where I share next week's event. So, coming Tuesday, you got to join us for a very special session on the proliferative verrucous leukoplakia, diagnosis and related lesions. And this is, of course, being taken by Dr. Rosna Zain, who, as we know, is one of the world leading authorities on the topic. So, this is like true blue oral pathology. So, please do join us. Of course, this is oral pathology, yes. So join us and it will be nice. Don't forget. Thank you all for being with us. And I also have to thank you for watching every week, for being with us, for all your likes, for all your comments, for the shares, for the subscribes. It is all this and all this love that you show that keeps us going and makes us come back every week with a new episode. So, see you. Have a great week and see you soon. Bye bye.
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 Bye.